Good afternoon, everyone, and I'd like to welcome you to the Minneapolis Heart Institute Foundation calling attention to Heart Valve Awareness Day, which was started in 2017 to try and raise awareness in the general public about the importance of heart valve disease as we grow older and how we can help with that. I'm Scott Sharkey. I'm a cardiologist at the Minneapolis Heart Institute, and I'm proud to say I'm also the Chief Medical Officer for the Minneapolis Heart Institute Foundation, and I'll be introducing our main speakers here in a moment. I'd like to take time to give a special shout out and thank you to our sponsors, Medtronic and Edwards Life Sciences, for this, their kind support of this program. A little bit about Minneapolis Heart Institute Foundation. We were formed in 1982, a long time ago now, and the purpose of our research foundation is to promote cardiovascular research and education, both of which are actually occurring here today. And we serve in partnership with the medical practice of Minneapolis Heart Institute physicians, who you'll be hearing from shortly. We're really proud of the impact that our cardiovascular research and education has had. We have some of the first in world valve heart disease implants. We have many community educational events, and our physicians present their research across the globe with respect to the findings that have been generated right here on this campus. And I want to really emphasize the importance of each one of you. Our research and education is made possible by the generosity of the philanthropic support of the community. So a big thank you to each and every one of you who have supported us along the way. In 2017, recognizing the importance of heart valve disease and the great progress that we've made in treating and diagnosing these conditions, we formed the Minneapolis Heart Institute Foundation Valve Science Center, led by Dr. Paul Sorajja, and Dr. Sorajja will be our first speaker. Paul Sorajja is the Roger and Lynn Hedrick Family Chair for Valve Science Research at the Valve Science Center at the Minneapolis Heart Institute Foundation. He is also a cardiologist and director for the Center of Valve and Structural Heart Disease at the Minneapolis Heart Institute. And I might add that Paul is known everywhere in the world for his leadership in heart valve disease, his knowledge, and his enthusiasm for helping patients. So we can't wait to hear from Dr. Sorajja, who will join us now.
Good afternoon to all of you. I want to welcome you to this event of National Heart Valve Disease Awareness Day. It is a real pleasure to be here. And in the next several minutes, we're going to be talking about the public health crisis of valve disease. We will follow that with a couple of patient stories and then a question and answer, which I hope all of you will find very beneficial as we celebrate Valve Heart Disease Awareness Day today. I first want to start with what is the function of heart valves? What are they, what do they do, and how do they help a patient stay healthy? Well, as many of you are probably aware, the heart, as we typically have it, has 4 chambers: the right atrium, right ventricle, the left atrium, and left ventricle. And these chambers are separated by 4 cardiac valves: the pulmonary valve, the tricuspid valve, the aortic valve, and the mitral valve. And what these valves do is they carry blood in one direction. The valves on the right side of the heart, the pulmonary and tricuspid valve, carry blood from the body to the lungs, while the aortic and mitral valves carry blood from the lungs to the body. And these valves are very important. They're vital to our health because they are dynamic and they open and close in sequence with the cardiac cycle, again, to keep blood moving in the correct direction. And so here's an example of some normal valves here on the left-hand side. You can see they often have multiple leaflets. The leaflets in their healthy state are thin, pliable, and easily move with opening and closing with the cardiac cycle. However, when they become diseased, As you can see here, they become thickened, often calcified, and this causes the valves to either become stenotic or too small, or they can also have regurgitation or insufficiency in which they simply leak. And when they're too small or when they're too leaky, we say that they are diseased and not functioning well, and at this point, they can start to affect a patient's long-term longevity. And so, how common is valve heart disease? And this is a slide that shows that valve heart disease is actually very common. This is a graph showing the relation between the prevalence of valve disease in the world and how that prevalence is related to the age of the patient, such that as we get older, valve disease becomes more common. And among those people over 75 years of age, 1 in 10 will have significant valve disease. And in the United States alone, there are over 5 million people who have valvular heart disease. Now, when we think about valve heart disease and how common it is, it's also important to keep in mind how it impacts the patient's long-term survival. Now, today is Valve Heart Disease Awareness Day, and we are here to help campaign about the need to be aware of the prevalence and impact of valve heart disease in our daily lives. Many of you are quite familiar with breast cancer awareness and prostate cancer awareness, but if you look at these different conditions, you still have to know, well, which one of these actually has the worst survival. It's not to demerit these other conditions, but valve heart disease actually has a more malignant course, and it's also more treatable. A patient with valve heart disease typically cannot live more than 1 to 3 years with the condition before the valve causes symptoms of heart failure and ultimately their untimely death. It's more malignant than even the most advanced cancers that's currently under treatment, and yet the way it's treated is much simpler. It simply requires surgical repair or replacement. Here's an example of how a valve is treated. This is transcatheter aortic valve replacement. On the left-hand side, you can see a heavily diseased valve right in the center, that thick, calcified valve that's not opening very well. And in the middle, there's a new valve that has been passed up from a patient's femoral artery, and using a balloon, a new valve is inflated inside the patient's own valve. And on the right-hand side, you can see the new prosthetic valve with normal leaflets opening and closing properly. And this is a procedure like many others that successfully restores patients' lives. And importantly, it can also be done with minimal sedation. So here on the left-hand side, this is an example of TAVR being done. I'm there standing in the middle. My anesthesiologist in the red coat is caressing the patient's head, and the patient has received just 0.5 milligram of midazolam and 50 micrograms of fentanyl. And this is less sedation than you would get when you're undergoing a colonoscopy. So just imagine that, the world that we live in today, that one is replacing valves in the heart with less sedation than one gets during a colonoscopy. It's actually quite remarkable, and it's hugely beneficial for our patients. And this is an example of this patient who the very next day is sitting up after having heart valve surgery and reading the paper. Now, with this in mind, it's also important to keep or understand that many patients with valve heart disease, despite their symptoms and their impaired longevity, still do not get treated. To illustrate this, here is a slide showing 10 people in orange who have valve heart disease. Well, how many of these patients currently get treatment? In fact, it is less than 1/3. So just imagine that for a moment. Patients who have severe symptomatic valve disease with symptoms of heart failure and a survival of only 1 to 3 years, but only 1/3 of them are getting life-saving therapy. And this is where we start to have that discussion about how valve heart disease is a public health crisis. When we look at the spectrum of life-saving therapy, there are many ways in which a patient's life can be saved by having their heart valve disease addressed. It can be done with a traditional open procedure, a minimally invasive procedure. It can be done with catheters that use their means to deploy valves, such as you see here. In essence, there are many options now to repair or replace a valve with minimal procedural risk. The procedural risk to undergo valve therapy is the lowest it's ever been. It's often 1 to 2%, which is quite remarkable when you look at the consequences of doing nothing, which unfortunately leads to poor survival and heart failure for many of our patients. As an example of how
I don't know what happened there, but okay.
As an example of how valve heart disease can change somebody's life. This is one of our patients who had valve repair, and then 3 weeks later is on a slalom ski, doing really well. As another example, this is Mabel. Mabel was 104 when she had her valve replacement surgery, and we asked her, why do you want to do valve surgery when you're 104 years old? And Mabel said, well, I have to go kayaking. And here she is in the hospital after having her procedure done. And then this is her celebrating afterwards at New Year's Eve, and then of course kayaking thereafter. So here are the facts when it comes to valve heart disease. Valve heart disease has a prognosis like cancer, and is worse than most advanced cancers. It's just as lethal as leukemia, lymphoma, and stage 3-4 breast cancer. It's a very lethal condition. There are incredibly effective treatments for valve heart disease. However, even though the prognosis of valve heart disease is so poor, and we have effective treatments for these patients, most patients unfortunately are not treated. And in fact, 3 in 4 people are not even aware of what valve heart disease is. And so we have today's event to celebrate that awareness with Valve Heart Disease Awareness Day. And in summary, when you think about all of these facts, we can do a lot better. So what can you do about valve heart disease in this spirit? Well, you can keep learning. We have our website here where you'll find plenty of education material about valve heart disease. There are advocacy groups that you can join. You can ask your care provider about valve heart disease. You can help us get the word out. For those of you who are active on Twitter and Facebook, these are some of the tags that you can use. But importantly, talk to your family and friends about valve heart disease. And if you have a care provider and you have concerns, talk to your care provider. Many patients with valve heart disease go undiagnosed, and it's important that you do get treated as you deserve to be. And with that, we'll turn now to our patient stories, and I'd like to thank you for your attention. And again, thank you for joining us in celebrating Valve Heart Disease Awareness Day.
I was involved with research for over 50 years, but it was all dealing with food and food ingredients. And
Larry was actually a pioneer in ancient grains, and in the food industry, he's known, well, he used to be known as the father of ancient grains. You know, Amaranth can.
now my son calls it the grandfather of ancient grains. They still don't know whether it was my heart caused my kidney failure, or because my kidneys were failing, it caused my heart to fail.
Because his heart was increasingly losing its ability to pump the blood.
I was getting a lot of backflow into my aortic side of my heart.
So he was had extremely short breath.
His forecast was I probably wouldn't be on this earth much more than 2 months at that point in time.
Yeah, he actually said, I wish I could tell you you have 2 months, but I can't. And he was taking Larry's files all over and calling doctors all over the world, trying to see if there was anything available. We were in his office in April, and he said, I have tried everything and everywhere, and there's nothing available, And while we were in his office, Dr. Sorajja called.
He was extremely excited, and as we all were, to give him the good news that if Larry were willing to come up to Minneapolis and participate in the study, that we have something that could help him.
Truly, it was, it was a miracle.
Dr. Goodwin graciously got the test done and then sent him to me, and I had him reviewed, and we thought Larry could be a great candidate for this new therapy, which was transcatheter mitral valve replacement. And this is with the 10-9 device. And at that time, we knew we had done just one case, and it was the first in the United States, the 7th in the world. And Larry, if he were to participate in the study, he would be the second patient ever in the United States to have received such therapy.
Dr. Sorajja was absolutely, we can see if he works, let's bring him in, I'll have Sarah set it all up, and we'll see. We can't promise you, because we can't promise individuals that they would qualify for something like this, but it was hope.
It was just like everything fell into place, just in the nick of time,
When Dr. Sorajja and Dr. Goodwin presented the little sliver of light through the wall, saying this is a way to escape through and bloom and see the sunshine, there was no hesitation on taking it.
As in any therapy, we simply don't know what we don't know. And that's part of research. It's part of being this field of new technology, is that whenever we're doing things new, obviously we understand some general terms about what the risks are, but they're just simply things that we don't know. And it takes a lot of bravery on the part of a patient to take that step. And that's exactly what Larry did. I look back on Larry and look back on our discussion with a lot of fondness.
He's a pioneer for sure.
Between Sarah and Dr. Sorajja, you could tell by their body language and by their words that they not only believed in what they were saying, but they were literally living with what they were saying. There was no question in my heart that he wasn't capable of doing what he was saying he was going to do. And because I trusted both Dr. Goodwin and I trust Dr. Sorajja even more, because he's the recent one who allowed me to see the sunshine.
These patients are doing so well, and this study is doing so well, and the valve is doing well, but it wouldn't be if it wasn't for people like Larry.
And thanks to him and Diane, we now have something that can benefit and affect in a positive way millions of people around the world. The therapy is now approved in Europe, and we're on the verge of having it approved here in the United States formally in its current phase of clinical trials, and it's all thanks to people like Larry and Diane.
I do remember thinking later how incredible that is, that in that amount of time, the course of a life can just so radically change. We still are, growing and discovering new things, and we have 7 grandchildren, aged 18 through 1. The 5 oldest are within 4 years of each other. It's just really a good life.
I'm Andrea Rose. I'm 81. I work out. We walk the dog. I used to love to play tennis, but then I had both knees replaced. And after that, I couldn't do it anymore. I had a heart attack about 5 years ago. I didn't have any damage at all. And Dr. Orlandi took over my case, my care. And he mentioned that my aorta valve was a little small. I felt fine, whatever. And he said, but they're doing a study over at Abbott Northwestern, and I think you would be a great candidate for that. And I thought, well, that would be good because it would be something for me and something that I could do for other people. And I went 2 times, and they said, you cannot be in the study because you need your valve replaced immediately.
When I first met her, it was clear that she's a lovely lady with no symptoms. She wanted really to show us how asymptomatic she was. So we managed to get her on a treadmill. She sort of did okay on the treadmill, but as we went forward with the evaluation, it was clear that she was becoming symptomatic.
The thing of it is, I was tired, but didn't know it because it's something that comes on you slowly.
Well, if we went for a walk or something, we'd have to stop. We have a walk that we take with the dog, okay? And then we're stopping places.
I had to rest a lot during the day, and I just gave it to that I was a little heavier and I was older.
And many of these patients think that this is old age. So I let them talk, and you can get a sense for what kind of biases they have.
So I was concerned that she had a problem, and my concern was that, what are you going to do about it? Can they take care of it?
Once you have the disease, you're going to need a valve replacement. The question is not so much if, but when.
They showed me the little valve, which is like tiny, and they said they go through the groin, they find it, and they just zip it right up and stick it right through the other one. And I thought, God, that sounds so quick. That sounds so good. And that's the other way. Would they open up the chest and put it in, and you have to stay in the hospital? Not for me.
They explain everything so well, and they give you kind of a history of other people that have had this procedure done. And people older than Andrea have had this procedure done, and it's been successful.
She underwent through the procedure, was very successful. And then I saw her in clinic 30 days after the procedure, and she hugged me, and she was very emotional. And the first thing she said is, I didn't know how limited I was.
Then I knew why I was so tired, because I wasn't getting enough blood going through to my heart and to my extremities and whatever. I mean, I feel like a new person.
It's like it was 10, 15 years ago, before she had this heart thing.
It was the best thing, and I would tell anybody not to be afraid of it. This was the easiest surgery I ever had, and I've had quite a few. And this is the easiest surgery ever. If my kids have noticed, and my grandkids, which are grown, have noticed, and then, of course, I've got these little kids that I can pick up, and I can do things with them, I can play with them, and there's no heavy breathing, and there's nothing to hold me back.
We do all kinds of procedures, interventional cardiologists, but this is certainly one of the most gratifying for us because consistently we see this type of response. In 30 days, you see a significant improvement in quality of life.
Well, I'm very thankful because it's improved her life, and as it improves her life, it improves my life.
I want to thank Dr. Garcia and his staff. They were wonderful, and I am so thankful that they gave me back my life. I feel like they gave me back a life. I didn't know I was losing it.
Well, those were just very powerful and heartwarming stories to hear on today's Heart Valve Awareness Day. And I want to give a heartfelt thank you to Andrea and to Larry for sharing their stories with all of us. And now I would like to introduce our question and answer period. We are opening this up to the audience. And we have a panel discussion. We have Dr. Garcia here on the left, and Sarah Olson, and Paul Sorajja is remote to answer your questions that you might have.
Well, I just want to say, Santi and Sarah, I love the videos, and I love seeing you on there. You guys look fantastic, and your impact on our patients and their lives it's really brings tears. It's hard to watch those without a box of Kleenexes. So thank you.
Oh, thank you for being part of this. I think is something that we've been doing for a number of years. Today is a different format because of COVID, but nonetheless, is glad to be present here with Sarah and the rest of the team.
Maybe if we could just start out with just some general questions. I mean, Santi, would you like to just kind of recap some of the issues that arise when you see patients with, valve disease? Like what today is about awareness. What would you describe as some of the barriers to that awareness?
Yeah, I think Andrea is a good example of one of the challenges we face with valve disease. Many patients think that is part of normal aging. In particular, aortic stenosis. Dr. Sorajja showed in one of the slides that the prevalence of heart disease increases with age. So many patients think that it's part of the normal process of aging, just being short of breath and not being able to do the things that they enjoy doing, etc. So that's one of perhaps the biggest misconceptions. The other one is we physicians sometimes have a hard time trying to tease out who has symptoms when patients are not very active. It's not unusual for us to see patients that have limited mobility come to clinic with a cane or in a wheelchair, and therefore cannot provide a history of exercise intolerance. So sometimes it's something that we have to be very thoughtful about when we label patients as being asymptomatic. Andrea was a good example that she thought this was part of normal aging and didn't make much out of it. It was going to be actually enrolled in a study that is testing whether we should replace valves before patients develop symptoms. And as part of the screening, we had to put her on a treadmill and do all kinds of tests. And only then we were able to demonstrate that indeed she was symptomatic and therefore needed to be treated. So something as simple as that, as determining who has symptoms that could be attributed to valvular heart disease, can be very important.
And you mentioned that she was being considered for a research study. Would you like to describe what study that was about and the rationale for that intervention?
Sure. So the current paradigm that dictates how we treat patients with aortic stenosis is one that has been construed over several decades and essentially calls for what we call a watchful observation of patients with severe aortic stenosis, patients that have very narrow valves but have not yet developed symptoms. And so we typically pull the trigger for valve replacement only when we see a combination of an abnormal echocardiogram and symptoms. This study is now challenging the paradigm and saying, why do we have to wait for symptoms when all kinds of bad things happen in the meantime? For example, we have learned from our imaging colleagues that patients develop left ventricular hypertrophy, the heart gets thicker. There's also fibrosis of the heart muscle, etc. So now that we have a therapy that can be delivered via transcatheter, patients awake, and the risk benefit is very, very different from conventional surgery, we're asking the question, should we lower our threshold? Should we offer valve replacement therapies earlier? And will that have an impact on patients' outcomes? So that's the main hypothesis of the study called Early TAVR, because we want to treat patients before they develop symptoms and see whether that's beneficial.
And so it really is about trying to get patients earlier in terms of therapy, isn't it?
That is correct. That is correct. We've been taught in medical school that we have to wait at least for lesions that are defined as stenosis, whether it's in the mitral position or in the aortic. wait for symptoms before you pull the trigger for therapies. And this assumption is based on very old data when the only treatment was surgery. Now that we have therapies that can be delivered to patients at a very, very low risk, we're trying to challenge our own biases and see if we can come up with better solutions.
And I think a lot of that has to do with just the fact that valve procedures have become so safe, and that enables us to go earlier because obviously prophylactic therapy, the basis of that is based on how safe the procedure is. Sarah, you know, Dr. Garcia is talking about research studies, and sometimes patients get frightened when they hear about research studies, and what would you say about being in a research study and how it affects care? I mean, obviously, on the video, Larry was part of a research study that saved his life. But how would you talk to other patients about being in a research study for valve therapy?
Well, thank you for inviting me to this Valve Awareness Day. I talk to patients a lot about research and the opportunity of what kind of devices we have here at Minneapolis Heart Institute Foundation that they may not be aware of or even know that they could be qualified for a research study to help them with their heart valve disease. So I educate them on the trial, and I educate them on the heart valve implant, and I talk to them about the history that we have here and what we've done so far here and how many people we've helped. And also I always talk to them that it may or may not benefit, but it may benefit the future. And a lot of our patients want to help the future. And that's what research is all about. But a lot of patients want help for themselves. And my experience is that the patients come to us after they've looked around and tried other things and we're not qualified for standard care. And they want to see the cutting edge that we have here at Minneapolis Heart Institute Foundation. So I bring them a lot of education and a lot of compassion.
Santi, when you talk to patients about being in studies, what do you find as some of the questions that they ask about? Is it daunting? Is it frightening? Or is it more of a, give me the latest innovation? How do patients talk about that with you?
I think my impression over the years has been that it really depends on where they are in the disease process. Patients with advanced disease that are very, very symptomatic are looking for hope. And those patients, I think, is a very different conversation than when you have someone like Andrea that is borderline symptomatic and just entering the phase where they may feel that something needs to be done. In regards to that, the early tower study, for example, many patients want to be treated as early as possible because they recognize that they're not going to be a better candidate for therapies in 2 or 3 or 4 years. They are, most of them in their 80s, et cetera, so they don't want to wait any longer. Others have the mindset of, if you can wait another year or so, why wouldn't you? So it really boils down to the personality of the patient at times. And I think our role is to try to provide some reassurance that every research study that we offer to patients has been during our discussions internally, and we certainly understand that some of the things we don't know, but many of these new devices have been extensively studied in animal models, et cetera. So I think it's incumbent upon us to try to educate our patients regarding these new devices.
Dr. Sorajja,
sorry, go ahead.
I would like to maybe pose a question to you from a perspective of a patient. Could you just share with us some of the stories or the symptoms that you hear from patients, some examples of what a heart valve problem feels like to them, so they understand what to be on the look for when you first see them in the office?
That's a great question because I'm actually in clinic remotely right now. So I've been seeing patients all day with valve disease, but it's quite remarkable, and it's very much like what Dr. Garcia was saying, is that a lot of times patients will minimize their symptoms because the symptoms are easily described as Andrea was describing, that it can feel like just simple slowing down. It can feel like simple fatigue or shortness of breath that, as Andrea described, I thought maybe I was gaining some weight or some other reason for the shortness of breath, but it turns out that it's valve disease. So it's often a mixture of those things: shortness of breath, some fatigue, chest tightness or chest pain, sometimes lightheadedness. But the important aspect is for the spirit of today's event of valve heart disease awareness is to recognize that, to not ignore these symptoms. And even if you find out later they're not related to your valve, it's best to get it checked out, because valve disease, unfortunately, is lethal. And while it's lethal, we do have treatments that can help, whether it's part of a research study or as part of a routine practice. And so getting it checked out is really what we're encouraging all of us to do.
And let me ask a follow-up question, if I could. They say that you have been found to have a significant heart valve condition, and yet you don't believe you have any symptoms. What kind of ways do you have to be sure there are no symptoms, and then how do you follow such a patient along to know when the right time to put in a new heart valve is?
Yeah, so it's very much along the lines of what Dr. Garcia was describing earlier about potentially considering a stress test. So sometimes patients don't have symptoms because they're relatively idle. So giving them an opportunity to see if they have symptoms, like on a stress test, is helpful. We also look at imaging studies to see if there's any hint of a change in the heart size or function. And if we see changes in the heart size or function, even in the absence of symptoms, we often get concerned. But it's usually a constellation of those different aspects, and taking that inquisitive approach to be sure a patient isn't having consequences related to valve disease is very, very important.
Thank you. And I guess, because I have all these questions that are on my mind as well. Can you tell us how patients are diagnosed with heart valve disease? So you go to your doctor's office and you get your annual Medicare checkup. What should I, as a patient, be making sure my doctor does to see if I do or do not have heart valve disease?
That's a good question. Maybe I'll start it and then have Santi and Sarah chime in. First of all, there are 20 million people in the United States who have some form of valve disease, of which 5 million or so, this valve disease is quite significant. And the reason why I bring that up is because if you have 20 million people have some form of valve disease, that means that 20 million people will have evidence of a murmur. And you might hear about that on exam. With a stethoscope, a physician can hear that turbulence flow across a valve that's either leaking or has become narrow. And so murmurs are actually quite common when you think about how many people have it. But then it's up to the clinician to then decide on the next study, which usually involves an echocardiogram, that it gets a really good look at the valve and looks at the function of the valve, how it's opening and closing, whether it's degenerated, and also how it's affected the heart in terms of the heart's size. So it usually starts with a stethoscope or a bedside exam after a history, followed by an echocardiogram.
Yeah, no, I agree with that. I was thinking as Paul was talking about stethoscopes, how much medicine has changed with COVID. And stethoscopes are now a thing of the past because physical exams are not what it used to be. But 100% agreement there. I think echocardiogram is probably the first test after an abnormal finding on examination. And then we oftentimes, in selected cases, we use advanced imaging. And the example The first patient that received a tendon implant, a CT, is critical for planning that procedure. In some patients with mitral regurgitation, understanding how much scar they have, as Dr. Calvacanti has shown us in his MRI publications, is very important to understand who is going to respond to mitral valve repair and who may not respond to that. So we use advanced imaging quite a bit to try to find what the best therapies may be for our patients.
And if I could ask you a follow-up to that, because you've done a lot of research on how COVID-19 pandemic has affected heart health. And as we've gone to more of a telemedicine type format, what kind of challenges does that pose for diagnosing heart valve disease?
Yeah, I guess the first challenge is for patients to understand that hospitals are safe and that we're open for business. I think the message, if you remember about a year ago, the first week of the pandemic, we told patients that if you have shortness of breath, you better stay home for 2 weeks, don't go anywhere because that's probably COVID. And we learned the hard way that many patients with heart disease miss heart attacks and never came to the emergency department. We were all preparing ourselves to receive this massive influx of COVID patients. And we started to notice that, yes, we saw some of that, but we also noticed a significant decline in heart attacks and also valve replacement procedures, et cetera, that was not related to the virus itself. But I think 1 year later, we understood that perhaps the psychological environment that we created, patients were really reluctant to come to the hospitals and see doctors in clinic. So the first message that I would like to convey is hospitals are safe. This is not the place where you're going to get COVID. Most of us are now immunized, and the patients that do have COVID are in a different area. So it's extremely unlikely that you will encounter one. And the second aspect is the telemedicine is certainly a good opportunity to at least talk to patients and get a feeling for how symptomatic they may be. And many times that could be the port of entry for then an in-person visit with dedicated studies to understand whether valvular heart disease is an issue or not.
But it is important for everyone to remember that the telemedicine visit cannot hear a heart murmur, and so there's no replacement for having a stethoscope on your chest, at least periodically, to do that. And then I could ask a question of Paul and Santiago also, if I could. This was submitted by the audience, which I think is a good one. And what ways are, if any, are there to prevent the getting heart valve disease? I'll start with you, Paul, and then I'll have Santi give his perspective.
Yeah, so I wish it were simple, but unfortunately, it's we can't choose our parents. Valve disease is it's genetic or it's determined by our own DNA. There really isn't a whole lot we can do in terms of lifestyle to prevent or improve it. Valve disease is very mechanical in its effects and its wear and tear, and it's just the nature of valve disease is to get worse with time. There are some valves that are when people are born, they're congenitally abnormal. That's the minority of cases. For the most part, patients who have valve disease, it's part of aging. And the only other preventable valve disease is rheumatic disease, which I think many of you probably are aware that when you may have strep throat, you want to take antibiotics so that way you don't get valve disease from the healing process of rheumatism. But apart from that, most valve disease in the Western world, unfortunately, is related to aging. And the only way to treat it then is with surgery. There are no medicines that can slow its progression. We can give medicines to help palliate some of the effects in terms of the excess volume, but it doesn't change how narrow, how leaky a valve is, unfortunately.
Santiago, do you have anything?
No, I think in general terms, it's correct. The only comment that I would make if patients are looking for advice, what can I do? I would say that at least for the mitral valve, sometimes he starts to leak after a heart attack. So the same recommendations that we make for patients that don't want to get coronary disease, exercise, diet, and staying active are very applicable to some etiologies of mitral regurgitation, but not all.
That is a very good point, to stay tuned to the basics of don't get heart attack. Sarah, if I could ask you, if I'm a patient and I want to know what research studies you're doing, how do I find out?
That's a nice, easy question. You could make a phone call to Minneapolis Heart Institute Foundation. You can also email them. You could reach out to Google and look up Dr. Sorajja, because he is very well known. You can go in and look for Dr. Garcia, and he's very well known. And between the two of them, they and sorry, I got a little distracted there. They're those two. If you look into just put their names in the Google, they'll come up, and that's a lot of phone calling, and phone numbers are in there, and also emails are in there. That's also ask your provider. You know, when you go to that doctor and he says, "Oh, I think I hear a murmur," say, "Well, what am I supposed to do about that?" And your provider will say, "I'm not a cardiologist, but I know some in Minneapolis that could help you or may help you." And that would be the Minneapolis Heart Institute Foundation Research and the Minneapolis Heart Institute Cardiology. So I would work there with just a phone call. A lot of my patients are extremely happy because it's so easy to get a hold of us as researchers. They dial a number and it gets transferred to any one of us. There's quite a few of us researchers. And if we can't answer the question, we can always go and find the answer for them. And so that's one thing about our patients. They always have such good positivity about how they can reach us if they need us. So I would say telephone and email.
Okay, thank you. I see you give kayaking lessons as well?
No, or I do not do skiing either.
Well, here's a good question also. How long, Santiago, I'll pose this to you first. And how long does my new heart valve last? And how do I take care of it going forward?
Yeah, so that's a work in progress. So just to give the audience context, these transcatheter valves, and I think your question is about transcatheter valves, were first intended for patients who were not good surgical candidates. And as you would imagine, many of those patients had limited life expectancy. Now we are implanting these valves in patients that are much younger and allow us to longitudinally follow these patients for many, many years, hopefully 10, 20 years after the valves are implanted. We have very good data from Europe and some of the early experience in the United States that we're now approaching a decade. Many of these valves have now been compared with surgical valves at 7 and 9 years even, and the durability appears to be the same, in particular for the new generation of transcatheter valves. Both devices approved in the United States, Edwards and Medtronic, are now in the 3rd generation, so there has been a lot of progress in the field. We're still awaiting data from the low-risk trials that are following these patients with a mean age of 70 for 10, 20 years so that we understand what's the durability of these valves. I personally think that it's going to be very similar to surgical valves. If you think about it, these are valves that are designed by the same companies, and they have the same anticalcific treatment, they have the same material, etc. So I will be curious to hear from Paul, but my sense is that we're going to have very, very comparable durability.
Paul, did you have to add anything to that?
No, I think that was very well said. You know, so far, we really haven't seen signs of early degeneration of our valve prostheses, and we continue to be hopeful in that regard. You know, it'll take years to get long-term data, but at least thus far, going out to even 8 years of follow-up, we have not seen any concerns of wear and tear. They are tissue valves, so you know, we know that they cannot last forever. But so far, we have not seen concerns with early wear, which is really, really great.
Well, since we have you on the line now, I'm going to end with the last question, and I'm going to ask you because of your stature in the valve world, and also Dr. Garcia, what excites you most at this time about the next big thing in heart valve research?
Well, I think, you know, the tricuspid valve is obviously the one that we're heavily focused on because, you know, from a transcatheter standpoint, we started with aortic and mitral and are moving to the right side of the heart. But what I'm most excited about, honestly, is that there's incredible innovation that's happening every day of our lives. I was on the phone with another colleague this morning, and we were just reminiscing about the fact that 5 years ago, we had no idea what we would be doing in the past 5 years. And the things that we're doing today, you know, patients I saw today in clinic, I wasn't even talking about just 3 years ago, which is just mind blowing. And so the pace of innovation in the valve world is just extraordinary. And what that really excites me about is that it gives us solutions for our patients. Because as I tried to say in my presentation earlier, these patients unfortunately can suffer, and many still go untreated. And we need to have solutions for everybody. And I think the innovation is going to help with that. And so I'm extremely excited to see what the next 5 to 10 years will entail. If they're even a quarter of what we've seen in the past 5 years, it's going to far exceed everybody's expectations.
So I think we have had a great hour or so with each and every one of you. I think on behalf of Dr. Sorajja and Dr. Garcia and Sarah Olson, that we want to thank each and every one of you of patients who are listening, because that's what this is all about, is the betterment of the lengthening of your life and the quality of your life, so that when you're 104 and you want to go out and learn how to kayak, that you can do that, or whatever else it might be. So thank you for joining us today. Paul, any closing words from you?
No, thank you for this opportunity. I want to thank our supporters, including our benefactors of our center, Roger and Lynn and John Turner as well, and the families that support them and support us. We're really grateful that we can do these sort of events, and it's all made possible by all of your support. So thank you.